EUS-guided embolization of a refractory splenic pseudoaneurysm. A 45-year-old female with decompensated alcoholic cirrhosis with portal hypertension, esophageal varices, loculated ascites, and large intra-abdominal and pelvic abscesses with multiple percutaneous drainage procedures presented as an outside hospital transfer to our institution for the management of a recurrent upper GI bleed, her third episode in 4 months. At the outside institution, she had previously undergone multiple upper endoscopies, notable for large gastric and esophageal varices, portal hypertensive gastropathy, but no active intraluminal bleeding was noted. CT angiography demonstrated splenic arterial aneurysm and pseudoaneurysm, for which our interventional radiology service had performed gastric and perigastric variceal obliteration, as well as 2 splenic arterial embolizations prior to this current admission. It is believed that her pseudoaneurysm was a result of chronic alcohol abuse and chronic pancreatitis. At presentation, she was hemodynamically stable with a hemoglobin of 7.1. A repeat CT abdomen and pelvis demonstrated a persistent splenic pseudoaneurysm, for which our interventional radiology service performed a third embolization. Unfortunately, post-embolization CT scan demonstrated a persistent pseudoaneurysm, with the patient requiring multiple transfusions. Due to continued transfusion requirements in spite of the interventions by our interventional radiology service, the decision was made to perform EUS-guided splenic pseudoaneurysmal obliteration with thrombin and cyanocrylate glue. Firstly, we tried to identify the splenic artery by use of power wave Doppler. Next, to identify the splenic pseudoaneurysm, we utilized color wave Doppler to identify the yin-yang sign, a sign created by the bidirectional flow of swirling blood within the pseudoaneurysm. Once identified, a 22-gauge FNA needle was advanced into the pseudoaneurysm. Contrast was then injected to confirm fluoroscopically the location of the aspiration needle within the pseudoaneurysm. "800 units of thrombin were then injected into the pseudoaneurysm. Color wave Doppler was used to confirm absence of flow within the pseudoaneurysm. Next, 0.5 milliliter of cyanocrylate glue was injected into the pseudoaneurysm. Of note, no coils were used during this embolization procedure due to the small size of the pseudoaneurysm and the previous coils placed by transcatheter arterial embolization, which flanked the pseudoaneurysm. Upon completion of injection of the cyanocrylate glue, careful withdrawal of the 22-gauge needle was performed with simultaneous flushing with sterile water. This is done to prevent clogging within the scope, as well as the formation of a glue cast which can rupture and cause recurrent bleeding. A 1-month CT angiography showed resolution of the pseudoaneurysm. Following the successful embolization, the patient no longer required any transfusions and has had no recurrence of GI bleeding for 11 months. Visceral arterial pseudoaneurysms are common sequelae of chronic pancreatitis with up to 50% risk of rupture and a non-negligible mortality. These are conventionally treated with transarterial embolization with good technical and clinical success. In cases of splenic pseudoaneurysmal persistence in spite of transcatheter arterial embolizations, EUS-guided embolization has shown significant promise with 100% technical and clinical success rates. In these situations of refractory pseudoaneurysms, EUS-guided approaches are useful. The main technical challenge involves identification of the pseudoaneurysm, identification of the yin-yang sign, and also using the location of previous interventions, such as coils, help to serve as landmarks. Careful withdrawal of the FNA needle is imperative, as any glue within the scope can result in the scope clogging, and any glue cast at the site of injection can later rupture and cause recurrent bleeding. As such, we recommend that while the needle is being withdrawn, that sterile water be injected through the needle. We also recommend that the needle stay outside of the tip of the scope for at least 30 seconds to allow any glue that may be on the tip of the needle to dry.